hello everyone. Good evening. Thank you again for joining me tonight. I'm glad to see you again. As you know, this is the second class regarding confrontation visual field tests. The previous class took like an hour and a half. This class will be a bit longer because we will try to finish the tests today, all the steps today. Please be patient. Try to be too focused and too attentive. So as you know, this class is all about analysis with the video that I shared. We will analyze together the video step by step, clip by clip, in order to be familiar with the proper way, a decent way to perform this test, okay, in order to pass the exam and in order to do it properly also in your clinical practice. And thank you for those who watched the video, because I asked you to watch it and try to observe the technique, try to speculate on what you see and notice any difference, any flaws, any mistakes, something might be missing, and so on. Okay, so I'd like to start with a message. We usually get that message from time to time, an inquiry about the proper way of doing the confrontation method. So will you please share correct method of doing visual field exams by confrontation method? It will be a great help. I searched the net, but didn't understand which is the correct method. That's true. There are many techniques, many steps, and a lot of variation. Okay, and there is a reason behind this. The technique itself varies from one institution to another, and sometimes in my institution from one department to another. So in neurology department differs from neurosurgery department, from ophthalmology department. And even in ophthalmology department, if you have a neuro-ophthalmologist, they might do it differently from general ophthalmologist. And I remember when my mentor, my professor taught me when I was a medical student, it was totally different from the standard technique nowadays. So there's a lot of variations. And if you check the confrontation test in older textbook, you will find a lot of details. And in recent references, the paragraph about confrontation test is a kind of rudimentary, a very short, because we all depend now on automated perimeters. It's more available and more convenient than before. But in the past, let's say in 80s and 90s, there was much dependence on confrontation test. Okay, but still, it is still a valuable test, a rough screening test. You have to do it in your clinic on every single patient, as we discussed in the previous class. All right. While I'm preparing my presentation in general, I don't rely on my background knowledge. I also double check with a lot of references. These are some of the books that I checked before conducting this class about the proper way. As you can see, it's all about neuro-ophthalmology, but I checked also references from neuro department as well, plus some articles from the net, of course, and videos. In order to come up with the most accepted way, I want to make sure that you are very confident and very comfortable with what you are doing, okay? And this is a very important mindset that you should have. Always aim at perfection. Although we know that we'll never be perfect, we'll never be like 100% perfect, but always aim at perfection, okay? For only then will you achieve excellence, because this is the only way to achieve excellence, is to aim at perfection. So that's my motto or my aim while shooting the video. And during the editing of video, I noticed some flaws. So I know that it's not 100% perfect. If you remember that slide from the previous class, I like to divide the confrontation visual field test into 3 stages. Evaluate, when you are sitting with the patient, doing the test itself, and then you are going to express or report the finding to the examiner, like the second stage. And the final stage is answering the examiner's questions regarding the case, the diagnosis, differential diagnosis, like correlation between your findings and a diagnosis, for example, and perhaps management, who knows. Okay, so, and I said before, confrontation visual test is a common test in neurostation, but it's not that very common. Why? For 2 reasons. First, it takes time. Okay, And the examiner usually try to give you 3 cases in 12 minutes. So because it takes time, so you don't usually prefer to ask you confrontation. This is one limiting factor, but it might occur. So you might be asked about confrontation test, but they usually don't allow you to do all the steps. But you should be aware of how to perform all the tests properly, okay? Number 2 reason, it is exhausting to the patient. The test itself, if you are going to do the whole steps in one patient, it would be exhausting because this patient will be the patient for the next candidate and the one after that and so on. So they try to not exhaust the patient because many candidates will see the same patient, okay? One more thing, in stage 1, I missed it to incorporate the examiner. Actually, examiner is there in all stages. The examiner in the first stage is observing you. Marking starts from the beginning, sometimes from entrance into the examination room. The examiner is fully watching what you are doing, how you treat the patient, how do you give the patient instructions. So this is really important. Also, remember when I said before, you should be talkative. So in stage 1, you are talking to the patient, but actually the patient also talks. So the patient responds. Okay, so it depends on the response. So there is a lot of talking here between you and the patient. And by the way, sometimes you need also to involve the examiner in your talk. So here the bubble, see the bubble from the candidate here, instruction to the patients, okay? And also involve the examiner in your talk. So you might say to the examiner, I want to check the vision first, okay? So the examiner might say, his vision is good, he's 6'6". So here the examiner is helping you to skip this step and focus on the next steps, and this is good. So you may say to the examiner, I would like to start by counting fingers on each eye first, and then using the white pen. So just give the examiner, let the examiner aware of what you are doing. All right. This class is all about the stage 1, evaluate. So the primary or the only objective of today's class is about the technique itself on a volunteer with normal finding. I'm not going to talk about any abnormal findings, and we are not going to talk about how to document or report the abnormal findings, okay? And as you can see here is the bill, okay? So it's very hard to finish all the stages. So sometimes you just do evaluation, okay, and the bill rank, but you are giving mark, by the way, on every stage. So don't worry if the bill rank before you finish. Again, because it takes time. The technique itself takes time. But the examiner can appreciate if you are a good candidate, a well-prepared candidate, or not that well-prepared candidate. Okay, so I have a couple of slides before we start analyzing the video. So remember, my first question to you in the previous class was about, is it important? We can rephrase this question by saying, why is it important? Or why confrontation test is important? And we mentioned 2 reasons from exam point of view to pass the neuro station, and second one in your practice, okay? But I forgot to mention 2 things. But before I add some more reasons, I want to talk a little bit, like a few seconds, about the power of asking why, okay? Because when you're going to see the checklist, the points you have to check, the points you are looking for in inspection and the steps of the technique, you have to ask yourself why, okay? It's a simple question, but leads to deeper understanding and connection of your ideas and better learning, deeper learning, okay? So we are not, like parrots memorizing information, cramming information. We are trying to understand as much as we can, okay? And this also, the kind of habit, this will encourage creativity later on. Let the learning process meaningful and fun at the same time. So we can simply say, asking why turns memorizing into understanding and learning into insight. It's the key to confidence, creativity, and growth. So why it's important, confrontation visual field test? If you remember during the pandemic, when the exam format was like totally different online, they asked the candidate to send a video recording on visual confrontation test. I think it was in 2021. And as far as I remember, there was a candidate who shared his results, and he actually didn't pass that step. But basically, because most of the candidates were not well prepared because of the hardship we were all facing, okay? So that shows that how this test is important. And Dr. Kaushik shared a PDF from American Academy. It shows the E&M guidelines, the evaluation and management guidelines for comprehensive eye exam. And as you can see here, after visual acuity, like check the visual acuity, you will find visual field. If I enlarge it this one, you will find gross visual fields. Mostly they are talking about confrontation visual field test. So it's important. Okay, so this is a checklist. I tried my best to make it like simple, and you have many points. We will discuss each point separately. I'm using the laser pointer. Be aware of the format or the design of the slide and how I designed this checklist. You will find like 3 big headings: intro, okay, inspection or observation, like this is the essential step in examining any patient, and then the test itself. So we have like 3 big headings, and we have subheading and sub-subheading. So the first one is an intro. It's like intro for any test in any checklist, and we covered it in the very beginning of this course. And it's all about like general etiquettes or general common sense, like you have to be respectful, you have to say please, thank you at the end. If you did something wrong, sorry, and so on, okay? And again, to be courteous is not about what you say, but also your body language, your eye contact, okay, and intonation, and so on. So this is actually a previous slide from the first class in this series, and using the infection, like disinfect your hand using the gel, yeah, short nails, and so on, okay? This is what I mean by intro, because in the video, the first clip was about intro and then dots. So dots means you have to revise what I said previously in the first class. The second point is about inspection, okay? In the chat, please let me know some of the points you have to be aware of during inspecting the patient in Neurostation. If you know that you are going to test visual field and you expect visual field defects. So some relevant points in inspection with visual field defects in Neurostation. I just want 3 points, at least. Yeah, acromegaly, right? Hemiplegia. So hemiplegia, so you can know hemiplegia from the gait and from being on a wheelchair, any squint, any ptosis. Excellent, excellent. That's enough. So by the way, I wrote here some points, okay? But this is not enough to say wheelchair, head tear, gait, speech, acromegaly. You have to tell me why. So every sign has its own why. But I'm not going to answer this in this class because we are not talking about abnormalities in this class, okay? So what is the significance of being hemiplegia with field defect? What is the significance of being acromegalic and field defect, and speech and field defect? So you have to make correlation. You are not just memorizing points and that's it. Okay, the examiner might ask you why you want to speak to the patient, because the patient is going to talk, okay? So you might observe a change in their way of speaking or the speech. So you have to comment on this. Here I wrote ptosis. Ptosis is a neurosign, but again, if it is significant, it might cause, as we said before in the previous class, superior field defect, iatrogenic field defect. So you might interest to ask the patient to or the patient to retract their upper lids, for example, okay? And how about prosthesis? This is, I think it happened once or twice. I think I saw it in one experience. The examiner asked the candidate to do a confrontation test on a prosthetic eye, and the candidate didn't notice, something like that, okay? So I wrote here something, it's funny right now, but if you imagine yourself the candidate, it wouldn't any fun at all. So like, congratulations, you did the test perfectly, but you failed the exam. Okay, so imagine you missed the presence of prosthesis and check the vision. The vision is no PL, of course, and like you told the examiner, the patient can't see. or like they have like total blindness. No, you have to be aware of these things. So if the patient has a prosthesis, you might need to do the confrontation test on the healthy side, for example. Okay. Now, this is the intro, inspection, and the test itself. We have three big headings. Let's start with the test itself. We have 2 points, something called like setup and clear instructions. Whenever you see both here, I mean by both doctors or the examiner and the patient. So we'll talk about these points because under the heading of each one, there is a lot of points by analyzing the video. I want someone to unmute and explaining what I'm doing in the video. So I want to talk about this slide first. Watching this video is not enough. You need to watch all the classes because, you know, it's not very detailed, and I wasn't talking during the video itself. There was like a background music, and also the angle of the video is like from one side. So it's very hard to appreciate the exact location of my hands and the targets from one angle. Okay, in order to video record confrontation, you need many cameras, like from different angles, even from the top of the, like above the examiner and the patients themselves, and one behind the examiner. So there is a kind of false perception or localization when you view a video from one angle, okay? And that's why I'm saying it's not enough. Again, tests because there are many steps. So this is about entry, and already talked about briefly about entry. Now, explain what I mean by writing down distance.
The thing is that it is a distance between the examiner and the patient that is very important. Both the patient and the examiner sitting opposite to each other should be at what distance? You have already written before, it should be 1 meter. So like almost arm length would be approximately 1 meter. This is about the distance between the examiner and the patient.
Thank you, thank you. So regarding distance, every reference writes the distance differently. So some use the feet, so it's like 2 to 3 feet, and approximately like 1 meter or maybe 90 centimeters. Or you can use the arm length. Personally, I like to adjust the distance by keeping a little gap between your knees, okay, and the patient
Okay.
knees. So your knees here and his knees. So just a little
Yeah.
gap, and that would be the perfect distance. All right. And you said both are seated. The examiner might be seated, by the way. So this test should be done while all participants are seated. Okay, thank you. Now,
Thank you.
so here, what I mean by level or height.
Yeah. So the height should also be same. The head level should be at the same level. I mean, one should not be above and the other should not be down. So it should be like at the same level so that the eyes can also face to each other's.
Exactly. Let's see here. So here I'm using like adjustable chair, so I make it lower
Yeah.
in order to
Yeah.
keep the eye levels at the same level, like both my eyes and his eyes.
Yeah.
And now, so if the patient is sitting on non-adjustable chair and is still lower, you can use a pillow or something to keep the same level as you said. Okay,
Yeah.
nice. All right,
Thank you.
the next clip. So what I mean by spectacles off, both.
Yeah. So spectacles of both means that there should not be any hindrance in the field between each others. because the rim can cause, the defects in the field. So it should be eye to eye contact.
Okay, I like eye to eye contact. Okay, right. Yes, exactly. But have you noticed that he actually took his glasses first, but then I asked him to, you know, this way. Actually, this is
Yeah.
not the ideal way for taking off your glasses. Why? So compare this way, this way.
Yeah.
I asked it to wear them again and then take off in properly. So what's the difference?
That could have hurt the eyes, or because the rim, it just took it off from the right to the left. So
No,
that's
actually,
not the proper way he should.
actually, this may actually broke this arm. So whenever you try to take off your glasses, you have to use your both, like holding the glasses from both rims at the same time. This is like something technical.
Yeah. Yeah. Okay.
And that's why I asked him to wear them again and to take them off properly. And
Yeah.
as I said
Yeah.
before in a previous class, yeah,
Yeah.
don't remove the glasses by yourself, by the examiner. So you should allow the patients themselves to take off their glasses, okay? This is
Yeah.
kind of like ethics here.
Okay. Okay.
And again, I took off my guy glasses.
Yeah.
And how about here, cap off?
Yeah. Because the cap can hinder the field, cannot compare the exact field with each other. So any hindrance has to be taken off.
Yes, but you have to be specific. You can say the superior visual field, okay?
Superior visual field. Yeah.
So either the patient can turn the cap around or they can take it off because some people like have like a strong relationship with their caps. Okay, they have like strong beliefs. They
Yeah.
so you can turn them around.
Yeah. Yeah.
So as you can see, inspection is not all about signs like acromegaly, but you have to see if there is something can cause a iatrogenic visual field defect like ptosis, severe ptosis, or spectacles or cabs, and adjust these factors.
Yeah.
Here, what I mean by head.
Head should be straight.
Yeah, fixed and fixed. Yeah.
Head should be straight and fixed. Yes.
Yes. So by convention, do we start with the right eye or the left eye?
Right eye.
Yeah, this is by convention. Unless the examiner stated otherwise, like unless they said examine the visual field of the left eye, or in clinical practice, if the right eye like has poor vision, you start with the eye with the better vision. Okay, so you can start with the left, but generally speaking, you start with the right side.
Okay.
And when we use the cover, there are different ways to cover. The patient can cover their eyes in different ways. So here, when it
Yeah.
comes to hand, what are the
Mm.
precautions here?
So the precaution is like you have explained to the patient that close it with your palm,
Yes.
because if he doesn't close with the palm, maybe the fingers, in
Mm.
between the fingers, he can see. So the fixation, I mean, of the right eye would not be exactly of the right eye field if he sees from the other eye.
Yes, exactly. So they might peek between the fingers. And also, they should not press on the globe, okay? So you have that
Yeah.
gently covering their eyes, because if they induce some pressure, when the time comes to test that eye, the left eye, it will be blurry, okay? Because this pressure in sustained pressure causes blurring, temporary blurring of the vision, okay? It should be gentle. Other
Yeah.
options, you can use a occluder or adhesive patch or something, but I think using their hand is the most convenient one or the most convenient method. Thank you, doctor.
Yeah.
Thank you.
Thank you. Yeah.
By the way, the room, examination room should be like very plain, like no decoration, no much stimuli, diffuse illumination, no source of glare, like windows and so on. So let's read together the setup. Distance 1 meter. The height should be the eye level and both examiner and patient seated. Background is blank without windows, illumination diffuse, and right eye first unless we mentioned the exceptions. The instructions, by the way, you should add this adjective, clear instructions, because giving patients vague instructions or incomplete instructions, you may get in trouble because the patient should understand what you are trying to do. And I wrote here both because there is some things you have to keep in mind because you need to adhere to some instructions, the examiners themselves. For example, how to place your hand and how you hold the targets. And here the instructions, I divide the instruction into 2 stages, like before starting the test, like spectacles, cap off, monocular testing, using your palm, gentle without pressure. And sometimes you need to occlude your eyes. The examiner should occlude the untested eye, the eye opposite to the patient's untested eye. There are 2 options for the examiner. They can use their hand to cover their eyes or just voluntarily close their eyes. And you will see this in the video. Again, for the patient, the most convenient way to cover their eyes, the untested eye, their palm. For the examiner, you can either using your hand or voluntarily close your eyes. Because sometimes you might need your hands. The examiner might need both hands to do the test. And throughout the test, still you need instruction. So you're always instructing the patient to fixate. We will talk about fixation in the next clip. The head should be stable. The examiner should have control over their hand placement and how they hold the targets. And there's something called shift hands. We will discuss it in a few minutes in a clip. Something called shift hands. Again, I'm trying to repeat information in order to help you to remember. So we have 3 big headings: intro, inspection, and the test itself. In the test, we have something like basics, like setup and some instructions. Okay. And then we have an important concept or important step, which is vision. And this is like a warning. So can you read this slide? Read aloud this slide.
Okay, vision. You need to make sure that the patient sees the target before testing by each eye. Target, count fingers or white and red pens.
Okay, thank you. So first, you need to check the vision. So there is a difference between saying vision and visual acuity. Okay, so visual acuity should be there must be number like 6/60. So there must be number. There must be charts, something quantitative. But vision is something more broader. It's may also involve like quality. So you have to have like a rough idea of the vision. You have to test vision by each eye monocularly. This is like a basic thing. You have be careful about this. You have to check vision by each eye separately. Okay. And what I mean by target here, the target that I'm gonna use to test the visual field. So there is a step called counting fingers. So I have to make sure that the patient can see my fingers and can count them correctly. Okay. There is a step for using white and red pens. So make sure that the patient can see the white pen and it looks white, and they should able to see the red pens and they look red. Okay. By target here, I mean the target that I'm gonna use to test the visual field. Don't confuse this with the fixation target when it comes to strabismus evaluation, because in strabismus evaluation, we sometimes use the same term, the fixation target, okay? The accommodative target the patient fixate on. But here, the patient here is fixed on the examiner's eye, and the target here means counting fingers, white pen, or red pen. So as you can see here, I'm starting with the right eye. So I want to make sure that he can count fingers, because the next step is counting fingers step. So this is the angle of photography that I told you before. Actually, I'm showing him here 2 fingers, but it might not look like 2 fingers, might look like 1 finger. But actually, showing him 2 fingers. 1 finger, 5 fingers. The next step is called counting fingers. We usually present to the patient 1 or 2 fingers and sometimes 5 fingers. But personally, I don't prefer 5 fingers because we try to simplify things. So it's enough to present to the patient 1 or 2 fingers. Okay. And here is a point about regarding fixation. So the patient should fix on the examiner's eye. Okay. In some references, you may find that the patient can fix on the examiner's nose, but it's better to fixate on the examiner's eye because you can monitor the fixations throughout the test. So better to ask the patient to fix his right eye on my left eye, on the examiner's left eye, and not the nose, in order to monitor the fixation throughout the test. You have to check vision before doing the visual field test itself. Spectacles off, each eye separately, and the targets here, counting fingers, white pen and red pen. Sometimes the patient can mimic or imitate the fingers. So if they are not able to say 1 finger, they can mimic using their hand, as we do in kids, because we can do confrontation visual field test on kids. Okay, so this is mimicking or imitating the fingers also works. This is an important slide. The most crucial instruction after making sure that the patient sees the target is fixation, because this is a test of visual field. So the eye should be fixed, okay, because we are not testing the fovea. So the eye should fix on something, and we present the target in areas surrounding the fovea. So here the patient needs to be told that confrontation visual field test is a test of the side vision and that they need to maintain central fixation at all times to look at the examiner's eye. All right. Here, 3 things need to be in check and to be monitored throughout the test. Fixation, the patient has steady fixation on your eye. Head position, patient's head position should be fixed and straight, as doctor said. And the examiner's hand, so the examiner's hand should be at the correct location and the way they hold the target, as we will see in few minutes. Okay, so this is regarding the point vision. So I highlighted in red because this is really important. The next point, or this is like considered as the first step in the visual field, in the confrontation visual field, counting fingers. And that's why I wrote step 1. So I wrote here counting fingers, but actually you can present just 1 finger, okay?
Right.
So just tell me the instructions that you are seeing right now.
So you've asked the patient to cover one of their eyes with their hand, and
Just
you're asking
1
them.
second. You have to be specific. Left eye, okay? So because I said before, the instruction should be clear. So you're gonna ask the patient here, I ask the patient or the volunteer to cover their left eye with their left hand, okay? Don't say any eye because you already have a photo here. You already have a video here. You already have the orientation here, okay? So you are not memorizing what's written in the book, okay? You have an actual case right now. So repeat it again, please.
You've asked the patient to cover their left eye with their left hand, and with their right eye, you're instructing him to look straight into your left eye and maintain fixation throughout the test.
Exactly.
And then you will explain to him what you need him to do.
So now I removed my hand. So, but still I'm covering my right eye, okay? Because I need both hands at this step.
Right.
So this might not be clear, and that's why I said this video is not enough. So actually I am closing my right eye. I am monocular as the patient or as the volunteer because I need both my hands.
Okay.
Here.
So you're holding your hands equidistant between you and the patient, and you are presenting fingers, and you've asked them to tell you
No,
how many fingers.
still there is no fingers here. You said something important, equidistance. So
Equidistant.
yeah,
Yes.
so this is like halfway between the volunteer and I. So this fist and this fist, what are the locations of these fists? Still, I am not presenting any fingers here, but I'm presenting fists, like closed hands. Name these parts of the field.
Your right hand is in the patient's infronasal field,
Yes,
and your
exactly.
left hand is in the patient's infrotemporal field.
Yes, exactly. Yeah, I'm gonna test now the inferior quadrants. Okay.
Right.
And now I'm testing the upper quadrants. So here is
Yes.
one
So,
of my mistakes, actually. This is a flaw. So see, okay, this is one of the flaws in this video. So you see this thumb should be not like this. It might be confusing for the patients. You should like hold up fingers, and this thumb should be retracted, like closed and retracted. Okay, but might be confusing.
okay.
So, and if you notice, the volunteer actually is talking. Who is telling me the number of fingers. So
Right.
look at the volunteer, he's talking. Thank you, doctor. Thank you. So make it simple, okay, because there is a lot of variation in this stage alone, but I'm showing just one technique, 1 or 2 fingers. Yeah, start by upper quadrants and then lower quadrants, or here, as you see, lower quadrants and then the upper quadrants in succession. So what I mean by in succession, you are not presenting the fingers simultaneously, because this is another variation in the technique, okay? As you can see, I'm testing one side and then the other, and then one side and then the other. If there is any abnormality, you can repeat to verify the abnormality, okay? So, but here we are talking about normal findings. But if you have a patient with abnormal finding, you have to repeat the step once more to make sure that it is consistent, because it's very important to make sure that the patient is reliable and your technique is consistent. So this is counting fingers, and sometimes they call it static counting fingers. You might see this expression because you present your fists, 2 fists first, and then you hold up your fingers. So the target is considered fixed. So this is called static testing. I would advise you to memorize it like static counting fingers in 4 quadrants. Always remember there are 4 quadrants. You have to imagine there are 4 quadrants: upper nasal, upper temporal, lower nasal, and lower temporal. Okay, and these 4 quadrants are divided by 2 lines: vertical meridian and horizontal meridian, intersecting at the point of fixation. So here, this is from book here, the fists, and then 1 finger at a time, like presenting the fingers 1 hand at a time. So here, using this hand and then the other hand, and so on. So don't forget to test all quadrants. I need someone to comment on this photo. There is no flaws, but I just want to repeat the instruction and explain if we are gonna give this photo a title. Yeah, please.
The patient is closing his left eye,
Yes.
and closing my right eye. I am introducing 2 fingers in the field. I think this is lower temporal.
No,
Okay.
don't say I think. There is no place for I think here. It's obvious. When something is obvious, don't say I think, okay? So this is called the line of sight, or the fixation, like visual access. You have to imagine this line. Just imagine this is like,
This is the inferior temporal.
okay, yes, exactly. So here would be above this line, like here would be the upper temporal, and here would be the lower temporal, okay?
Okay.
Thank you. And I like the way how he presented his fingers because they are very separate to make it clearer to the patients. Okay. So he's examining the lower temporal, you can say he examining the lower temporal quadrant, okay, of the patient's right eye. Can you read that aloud, please?
Testing visual fields to confrontation in the infratemporal quadrant. The examiner is at the same level as the patient and has his fingers equidistant between the patient and himself. The patient is fixing on the examiner's left eye with his right eye and has his left eye fully covered by his palm.
You just missed the word palm. I was waiting for the word palm. Okay. Thank you so much.
Thank you.
So how do you present your fingers? Hold up 1 or 2 fingers. Some reference may say 5, but I think 1 or 2 is more than enough. In 4 quadrants, your hand should be perpendicular to visual axis, side by side. So what I mean by this? So as you can see here, this is the correct way to place your fingers. Like it should be like side by side along the frontal plane. Okay. And if you imagine this plane is actually perpendicular to the line of sight or the visual axis. But presenting the finger like this, like obliquely or in any other direction, it might be confusing. The patient may see 2 fingers as one. And as doctor said, your hand should equidistant between you and the patient. Because this is called static testing, you have to present your fist first, not your hand first or your closed hand first, and then hold up the fingers. All right, and as you can see here, the examiner is testing the right eye, and the patient here is holding a occluder. She is not using her hand. All right, there is a kind of mistake, might be a mistake, or maybe again false perception because the angle of viewing or photographing is not correct. So this is the correct way, side by side. But another flaw that might be in the photo, as I just said, just imagine 4 quadrants. So your fingers should be held in each quadrant separately. So this finger is actually crossing the horizontal line. Okay, so again, it might be a false appearance, like false perception, but be aware when you are presenting your fingers, you are respecting the meridian. So you are testing the inferior temporal, for example, alone. Don't cross the horizontal meridian or the vertical meridian. Okay, because this is another mistake you have to be aware of. Here the patient is using adhesive plaster. And again, this is, if we are going to comment on this photo, here the examiner is testing what the superior quadrants, the superior nasal and the superior temporal of the patient's right eye using the static counting fingers technique. What is the next step? Using the neurological pins. We have white pin and we have red pin. So what's the difference? A silly question, but let's see your answer. What's the difference between white pin and red pin? In terms of morphology, let's say in terms of morphology. Yeah, I know it's silly, but don't underestimate my questions. Please try to answer it. It's an easy question, so you have to interact.
Hello, ma'am.
Hello, how are you?
Yeah. Hello. Yeah. I'm fine.
How was your day?
Yeah, it's good.
Do you like jokes?
So yeah, I like I like jokes.
Okay, so be prepared.
Okay.
You are gonna tell us a joke at the end of this meeting. Unless
Okay.
unless you leave the meeting before I end.
No.
Okay,
So yeah, the looks like the red pin
this
is a
is a
little small.
so what I was trying to do is kind of distractions. So you have to try to keep your thoughts flowing, even if there is a lot of distractions around you, because there might be noise, other candidates, other examiners, okay, many patients. So you have to be focused on your thoughts.
Okay.
Yeah, please go ahead. Sorry for interruption.
So, I mean, size-wise, the red pin looks a little smaller than the white pin, the ball.
Yes.
And white pin is generally used for that peripheral vision testing, and the red pin is used for central vision field testing.
Okay, thank you. That's enough. But my question actually was about the morphology, like the morphology of the pins
Yeah, the
themselves.
size.
So
Okay.
you just mentioned one point. So that's why I said it's a silly question. So one is white and the other is red. This is number one, and one is bigger than the other. Okay.
Okay.
So two things, and if you want to be more specific, sometimes you recommend that the white pin is 1 centimeter and the red pin is half a centimeter. Thank you.
Okay.
I showed this before, but I forgot to mention things here. This is the commercially available neurological pins, like 2-in-1, just in case you want to mix like this. As you can see, 1 centimeter is the diameter of the white pin and 0.5 centimeter is the red pin. And it is called here matte white and matte red, because it should not be glowing or have a luster. It should be something dull, like dull white and dull red. And the rod itself is about like 10 centimeter, 11 centimeters, and it should be like gray or black. By the way, if you look carefully at the steps, we usually start with something big, crude, gross, okay? Because counting fingers, our fingers are the kind bigger than the pins. So we start with the biggest, then the finest. So we start with counting fingers. The next one is white pin, and then the red pin, because red pin is smaller and we can use it to detect subtle scotomas in the central field. So we are trying to refine the technique as we go further, okay, in the steps. So this is step 2, white pin. So as you can see, you have to be prepared. I already have my pins in my pocket, so I just bring it. So can you explain this? Mapping the extent or the limit by the white pin. What extent? What limit?
I think the degree of peripheral visual field, like it's
Yeah,
temporarily
the outline.
Outline. Yeah.
So remember
The peripheral.
Yeah. So remember the concept of the hill of vision. So you have an island. You try to map or outline the border of the island. Okay. So you are gonna bring the pin from non-seen to seen. Like the first point, the patient can see the white pin.
Okay.
So here, this is in the cloud, what I wrote.
Can you see this pin?
Yeah, don't forget that you have to check vision. Can they see the target, the white pin or not?
Yeah.
Okay. And whenever you check the vision, the target should be exactly in front of the eye. Okay. Any visual testing should be like in the primary position, like straight in front of the eye.
Right now. So first,
yeah. So can you see I am always talking? If you notice my lips, I'm always talking.
So after asking him to close the left eye and your right eye you have closed, you have brought this white pin in between in the middle of the distance between you and the patient. And then you have asked the patient to look straight into your eyes, and you have in the white part of the pin superiorly.
Superior temporal. This is I'm testing here the superior temporal quadrant. Okay.
Yeah, supratemporal quadrant. Okay. Yeah, you have asked him, you have brought the pin at the supratemporal quadrant. I mean,
What,
right
what,
now it is at the supratemporal quadrant.
what is the instruction at this point?
Yes. So you are asking if he can see the pin, if he can see the white part of the pin or not.
Okay, you start from area not seen until they first notice the white pin.
Yeah. So
Okay.
you are asking if he can see or not. So
Okay.
yeah.
But still there is a missing word here. Remember, this is a confrontation test. So both
Yeah,
of you should see the target at the same point. Okay?
exactly. Yeah.
Yeah. So because this is a comparison between your visual field, the examiner's visual field, and patient's visual field. So
Yeah.
you start very far, like beyond
Yeah.
the normal limit of the superior temporal quadrant, where this pin is not visible to either of you, and move diagonally, okay, until both of you see it at the same time. Okay?
Yeah.
By the way, it's not only about your hand, the location of your hand equidistant,
Yeah.
but also how you hold the target. So the
Yeah.
orientation, it should be like this. The white ball should be directed toward the line of fixation, to the center.
Okay. Okay.
Okay. Sometimes the orientation of how you hold the target is important as well. So it's
Yeah.
not only equidistance and that's it. No, how you hold the pin itself. Okay.
Yeah.
Make the
It should
target, the white pin, the first thing the patient can see. And it should be like oblique, diagonal like this.
Okay. It should be diagonal. Okay. Yeah.
And you move slowly. When the patient sees, you stop. Some practitioner may continue until the fixation point, but again, we keep testing the central field to be done with the red pen. Okay, white pen, we just want to see the limit, the outer limit of the field, the outer limit of the peripheral field. So once the patient sees the point and you see it at the same distance or a same point, that's normal. Okay, if you see the white pen, but the patient doesn't see it, so there is a defect in the outer limit of the visual field. But this is, we are testing now on a volunteer. Now I'm testing what?
Yeah, now you are testing infratemporal part.
Yeah, again, make your hand equidistant and the way you are holding, notice how I hold the neurological pen, okay?
Yeah.
And move slowly until
he sees and you see.
Yeah, at the same time.
At the same time.
I'm just repeating the test here.
Yeah.
So now this is called shift hands.
Yeah.
Okay? So you have to shift your hands while testing the nasal field.
Yeah.
And again, note here I'm testing, I already finished the lower nasal, and here is the upper nasal. It was a bit fast.
Infranasal and supranasal.
So note here how I hold the neurological pen.
Yeah.
And here is the upper nasal. Okay, nice. Thank you.
Thank you.
So again, you can imagine now how we tested the outer limit of the visual field with the white pen. Always remember there are 4 quadrants to be tested. And see, this is the neurological pen here. I'm pointing at one. This is upper temporal because this is a blind spot. This is temporal field, which is wider. So this is a blind spot here. So this I'm testing here the upper temporal, and you then place in the lower temporal. And don't forget to shift your hands and present the target on the nasal fields, upper nasal and lower nasal. I'm using now the animation, so be careful in order to show you the orientation. So how do you hold the neurological pen? The ball the ball itself should be directed toward the center of fixation, like and diagonally. See the movement? The patient sees at this point, this is the outer limit of the visual field. So you stop, and that's enough. You move from non-seen to this pin is non-seen, and you move it until seen, until it's seen. The other side, upper nasal, you stopped once seen, and here's the lower nasal. And you imagine this outer limit of visual field and should be similar to yours, to the examiner's visual field. So this is a basic concept of wide pin. In the next two classes, we'll discuss abnormalities. So this is like an example of normal outline. But suppose the patient sees these pins like here. So this is a constricted visual field, for example. And you have to know what are the causes of tunnel vision or constricted visual field, like diffuse, overall diffuse restriction of the visual field. But today is our focus on normal, on the technique itself. We use the white pen to outline the outer extent or the outer limit, the border of the halo vision. And once the patient sees the target, we stop moving the neurological pin. Is it clear?
Yeah, ma'am, it's clear.
Okay. Okay, so this is the third step.
Yeah.
Yes.
So first we'll put the red pin at the center and check for the central. I mean, can ask the patient, can you see this red pin?
Yeah, and it should be seen as red. So you have to make sure
Should
that
be seen
it is red, okay? Because
right.
he might see it washed out, for example, or gray. So this is an abnormal finding, and we
Okay.
can talk about it later. But you have to make sure that they can see it as red. And generally speaking, we use the red pen for what?
For central fields, to examine the central fields.
For
For
any?
scotoma, central scotoma. I mean, enlarged blind spot or
yeah, any scotomas. It could be
any
central,
scotomas.
paracentral, the blind
Okay.
spot itself, which is physiological. Okay.
Okay.
Anything you want to examine in the central field,
Central
it's
fields.
better to use the red pen. If you want to
Okay.
use the white pen, it's not incorrect. It's not incorrect. You can use it, but in order to improve the sensitivity of the test, you need a smaller target and you need the red color. Okay.
Right. Right, ma'am.
So the starting point. So if you compare the starting point of the white pen versus the starting point of the red pen, you will notice that the red pen will usually hold it like not too far. Okay.
Okay. Okay, ma'am.
What is the instruction you are? So what is your instruction to the patient at this point?
So at this point, I'll ask him whether he's able to see the red pin coming from the superior temporal quadrant.
Yes, throughout the movement. So it's not enough
Okay.
to see that when he first sees a red pen. No,
Okay.
he should see it all through.
Throughout the
throughout the movement until the fixation point. So see how my hands move.
Yes.
And here, what is the quadrant?
This is the inferior temporal quadrant. I'll ask him whether he can see the red pin throughout the movement of the hand till the fixation point.
Until
Till
the
the
line
fixation.
until the line of fixation. Shift hands. Don't forget shift hands.
And then again, after shifting hands, I'll bring the red pin from the superior nasal quadrant and ask him whether he can see the red pin till the point of fixation. And again, coming from the infero nasal quadrant.
So you see,
I'll ask the patient.
Encourages the patient to fixate on your eye throughout the test.
My eyes. Yes, yes. Yeah. And then again, I'll bring the red pin from the infero nasal quadrant and ask him whether he can see that pin throughout the range of movement till the fixation point.
Normally, it should be visible all the time. Okay.
Throughout the movement.
Yeah.
Yes. If there is any scotoma, then I think that can be a
Yeah, we can talk
Yeah.
about it later in the next classes. Okay.
right.
This is the technique or how we use the red pen. Thank you.
Okay.
So let's see the animations. You don't need to start very far, okay? Because we are gonna test the central field, like 30 degrees here, here, like 30-degree radius. As we remember, we divided the visual field into central and peripheral. So you don't need to start very far. And see the animation here. So we move the red pen, here is the upper temporal until the fixation point. And here the lower temporal, and here the upper nasal, and here the lower nasal. Normally, the patient should see the red pen as red, don't forget, as red throughout the movement. So we use the red pen for examining the central field for anything, scotoma, any kind of scotoma, and other things. We will discuss it later in the following steps. So this is again a diagram showing you how you move your red pen diagonally, okay, in 4 quadrants until the line of sight. We finished step 1, counting fingers, step 2, white pen, neurological pen, step 3, red pen. The next step called blind spot mapping. So step 4, the blind spot mapping. First of all, just remind us of the instruction that you see right now. Okay, so monocular testing, we are testing the blind spot of the right eye, okay? The patient or the volunteer is covering his left eye with his left palm, okay? And I'm covering my right eye. And I'm gonna use the red pen. So when you are gonna test or to localize the blind spot, you need the red pen because the blind spot is in the central field. And we said before, anything you are gonna do it in the central field, it's better to use the red pen. Okay?
Okay.
And don't forget to ask the patient to fixate, because if the patient doesn't able to fixate, okay, you will never find the blind spot. So fixation is really crucial during this step. The patient should fixate on your eye, on the examiner's eye. Okay, I'm gonna explain it for the sake of time. Okay, so there are 2 ways to map the blind spot. I'm showing here the easiest. I believe this is the easiest, to start from the point of fixation. Okay, to start from the point of fixation. So already the patient sees, because we checked the vision and we already know that the patient or the volunteer sees the red pen. So we start from the central, like along the line of sight, along the visual axis here, from the center. And we should move it temporarily, like laterally, because the blind spot in the temporal field. So again, you might not able to appreciate my hand's movement because it's so subtle, because the blind spot is not too far from the point of fixation. Okay, so here I'm always talking to the volunteer, because he should say, I see this red pen, and I'm gonna instruct him to tell me when he no longer see it. So I'm moving it laterally toward the temporal field and slightly lower until one point neither of us can see this red pen because it's already in the blind spot. Usually the examiner will be satisfied at that point, and there is no time for any additional steps. But actually you can map it, like you can outline the area of the blind spot. So you are trying to figure out the upper extent and the lower extent, the nasal extent and the temporal extent. But remember, all the blind spot is located in the temporal field and slightly lower. Okay? So to find the blind spot, move the pen from the point of fixation halfway between you, laterally. Laterally means here temporally, along the horizontal meridian until you find your own blind spot. Ask the patient to tell you when the pen disappears. Normally, both for you and for patient should disappear at the same point. You may find in other references that they move the red pen not from central to periphery. They start from the temporal. Okay, so my way actually is start from the central, the fixation laterally. The direction should be laterally. In other references, they may use the other way. They start here from area seen and move nasally. But this is harder. I believe it's harder. So let's see this animated slide. Okay, so this is the blind spot. I want to locate the blind spot. And I'm holding the neurological pin, the red pin in the center. I'm moving laterally. And once in the blind spot, it's no longer visible, okay? And that's enough. But you can map the dimension by moving it more laterally until it's seen again. So by this way, you have an idea about the temporal limit and the nasal limit. And you can also return back to the blind spot and move it down to have an idea about the lower extent, and back again to the blind spot and outline the upper extent to have an idea about the size of the blind spot, comparing your blind spot to the patient's blind spot. Remember, this is a comparison test. Confrontation test is a comparison test. Is that clear? You can just find the blind spot and that's it. Or if you are interested, you can map it just for fun. But there is no time for this in the exam, actually. This is again from my video. The concept of mapping the blind spot, the upper and lower extent, the nasal extent, and the temporal extent. So I'm saying the nasal extent, but the blind spot itself in the temporal quadrant. This is your time to tell us a joke. Turn on your imagination, and we are gonna play a role play. Okay, you will be the examiner, and I will be the candidate. I'm so frustrated, as you see. Okay. So whenever you see examiner, you will have to say what's written in front of it. Like right now. Yeah. Make your voice louder and harsher and like, yeah, imagine you are a cruel person, like very tough.
Map the blind spot of the right eye.
Oh my God, that's really tough. Okay. So as you can see, there is no please or kindly, but we are like exaggerating the situation because this is not a real situation. So the examiners are too kind, too polite, too respectful as well. All right. Can you say it again? Because I really liked it. So say it again.
Map the blind spot of the right eye.
So be careful. Okay. So I tried many times, but in vain. Sir, I failed to find the blind spot.
Actually, you failed at two things.
How? Now you can imagine the rest of the scenario. Can you imagine?
No, ma'am.
Okay, first.
Okay.
So the candidate already said I failed to find the blood spot. So this is one failure.
Okay,
so,
okay.
Okay.
And you failed in the exams also.
Yeah. So, of course, the examiner are not allowed to tell you the results, and you are not allowed to have like a rationale or justification.
Yes.
So you failed to find the blind spot. This is number one. And you failed at the station because you were mapping it in the nasal field.
The nasal field.
Okay, so be careful. You are trying to find, if you are trying to find a fish in the desert, you will never find a fish in the desert. So
It's
Try
always in the
to,
temporal
yeah,
field.
in the temporal field. Okay. Thank you. So here is some inequalities in confrontation visual field testing. If there is abnormality like homonymous hemanopia. Now, I shouldn't go to the blind spot test or have to show the examiner how can I can do so. So in order to locate the blind spot, we depend that it is surrounded by areas with normal vision. Okay. If there is a half of the field is defect, like here is like the half of the field is like blindness, there is no vision in the temporal field. I'm talking about the temporal half. So if the temporal half is affected in the homonymous, so in homonymous hemanopia, one temporal field is affected in one eye and one nasal field on the other eye. So the temporal half, you will not able to map the blind spot in the blind temporal field. Okay, in order to find the blind spot, there must be a surrounding scene area. Okay, so regarding this question, this is my reply. You can explain to the technique orally. How do you find the blind spot to the examiner? Again, in hemanopia, there is a temporal field affected in one eye and nasal field affected on the other eye. So the eye with the nasal field affection, you can test the blind spot on the unaffected temporal field. I don't know if it is clear or not. So can you see this slide? This is homonymous hemanopia. This is the right eye. This is the temporal field. And this is the nasal field. By the way, this is a right homonymous hemanopia or left homonymous hemanopia? This one. We will talk about this later when we are going to talk about cases in the following two classes. But this is what. Let's see the chat. Because,
left homonymous hemianopia.
And this is right homonymous hemianopia.
Yeah, this is right homonymous hemanopia. So this is, by the way, if you say left homonymous hemanopia and the case was right homonymous hemanopia, so you messed up the laterality, the side. I'm sorry to say that you might fail that case, okay, because this is a fatal mistake. But we are gonna talk about it, don't worry, in the next two classes in order to avoid that confusing piece of information. So this is right homonymous hemanopia. Anyway, it's not our topic now. But here, as you can see, where is the blind spot? The blind spot here disappeared in the blind temporal field here. You will never able to map the blind spot in this field, but you can map the blind spot on the unaffected temporal field of the other eye. Okay, so this is the explanation of my reply to the inquiry or the question about mapping the blind spot. So you can explain the technique orally, and you can do it on the normal unaffected temporal field. Okay. Practically speaking, if there is homonymous hemanopia, this is the abbreviation for homonymous hemanopia, the next step would be something else called macular sparing and something called obeying the vertical meridian. This is another step in the confrontation visual field test that we are going to talk about it now. Then answer some follow-up questions given by the examiner regarding homonymous hemanopia. Again, let's summarize these pieces of information. In order to locate the blind spot, you should search it in the temporal field. If you search for blind spot in that field, you will fill the station. Okay. Number two, there must be surrounding scene area. So this area, let's say the quadrant or the half temporal field should be normal. And another thing, the patient should fixate on your eye. If the patient switches fixation, you will never able to find the blind spot because simply the patient might be looking at the red pen by his macula. And this is another photo from a book. It shows that how the patients and the examiner should locate the blind spot at the same point. If you are holding the neurological pen in the exact location, equidistant, there must be coincide. The moment you don't see the red pen, it should be coincide with the patients. And this is view from above. All right. So we finished the blind spot mapping. The next step is something in video. You will find it macular sparing and something called obeying the vertical meridian. And we usually do these two steps in HH. So what does this abbreviation stand for?
Homonymous hemianopia.
Yeah, exactly. By the way, is it homonymous hemanopia or homonymous hemanopsia? Actually, both are correct. Okay. In my area, we usually say homonymous hemanopia. Okay. In some places or in older textbook, you may find hemanopsia. But actually, if you check the dictionary, you will find hemanopsia is the same meaning as hemanopia. It's just one variant. They differ from the Greek roots because hemi means half and means abs without, like there is no vision. And opia means vision, but opsia from opsis means sight. So sight, vision, almost similar. So if you are familiar with the homonymous hemanopsia, it's okay. If you are going to say homonymous hemanopia, as I say, it's correct as well. So back to this slide again, we have something called HH, homonymous hemanopia or hemanopsia. It's not enough to say this, for example, you have to say the side. For example, this is left homonymous hemanopia, and this is right homonymous hemanopia. And by the way, this is like complete. The whole half is affected. How about this? I am pointing to what we call this defect. I said we are not going to talk about abnormalities, but I need to talk about this for like a few seconds in order to demonstrate the following steps in the examination. What we call this?
Binasal hemianopia.
Yes. And what we call this one on the right, at the right
Temporal
button?
hemianopia.
Okay. So collectively, we can call it heteronomous hemanopia. That's again, it's HH, but we usually don't say this term. We usually say, as the doctor said, binasal hemanopia and bitemporal. So HH means homonymous hemanopia. And heteronomous hemanopia doesn't have an abbreviation because we don't usually use this term. We usually say binasal and bitemporal. And please note the color code. I wrote this in green, gray and gray because we seldom talk about this term. And binasal hemanopia is again a rare condition, but I wrote bitemporal hemanopia. It's an important disorder. You have to be like fully aware of it. Bitemporal hemanopia. Okay. How about this? So if you remember here, the defect is like respecting the vertical meridian. So we call it respecting or obeying the vertical meridian. And how about this? When we have a half that's respecting the horizontal meridian, what we call this defect? This is on the right eye.
Inferior hemifield defect.
And this is a descriptive term, but it has a medical term.
Altitudinal.
Yes, exactly. Excellent. If we have a defect like involving the inferior quadrant, inferior temporal, and inferior nasal, there is an additional step to see if this defect respects the horizontal meridian or not. But more importantly is this one. If we have a defect that like involving the upper and lower quadrant, whether it's temporal or it's nasal, you have to see if they are respecting the vertical meridian or not. And that's why there is a step called respecting the vertical meridian. Okay? And again, this is a right homonymous hemanopia, respecting the vertical meridian, of course. But there are two types of right homonymous hemanopia, this one and this one. Do you know what we call this one and what we call this one? So this is the right and left eye of a case, and this is the right and left eye of the case, another case. Both are right homonymous hemanopia, okay? Respecting the vertical meridian, of course, and complete, like the whole temporal half here and the whole nasal half here. But what's the difference between the above case and the lower case?
The lower case, there is macular sparing.
Yeah, as shown on the slide, yeah, it's visible on the slide. The lower case has something called the macular sparing. So the central area is spared, is not affected. Okay, does anyone know what we call the upper one?
Complete homonymous right complete homonymous hemianopia.
Okay, yeah, smart answer out of the box. Yeah, it's non-negotiable answer. Yeah, but we can add something else. We can say it's macular splitting.
Involving.
Splitting.
Okay. Yeah.
Yeah. All right. So whenever we have homonymous hemanopia, there is a test for something called, we need to know, is it macular sparing or macular splitting? Okay. And there is a step also to see if it is respecting the vertical meridian or not. So let's see the video clips. So I said here additional test steps. So we do this if we find homonymous hemanopia. Again, we do macular sparing if we already find homonymous hemanopia in the previous steps. So we are gonna hold the red pen like on each side of the line of sight. Yeah, it would be very difficult to appreciate from the video because the volunteer already has no abnormality. So I'm gonna show you the animation first because it would be easier to understand from animation. So if we have like this case, right homonymous hemanopia, so patient can't see this red pen and we move it and we find that the patient sees the red pen once we crossed the vertical meridian. So not seen here and becomes seen here. So this means the macular area here is involved. So this is called macular splitting. So by the way, there is a macular fibers here, or this area represents some macular fibers, and there is some macular fibers here. Okay, the central 5 to 10 degrees actually called the macular, or represents the macula. So again, the animation, we move it like this across the vertical meridian, just from the temporal to the nasal. So if the target is not seen here, but seen once we cross the vertical meridian, this is called the macular splitting. How about the other one? The other one, the pen is not seen here, but the patient is able to see the target before crossing the vertical meridian. So this is called macular sparing. So what's the difference? On macular splitting, the patient can see the red pen once the red pen crosses the vertical meridian. But in macular sparing, the patient can see the red pen just before crossing the vertical meridian. And here is the paragraph to explain the technique. When there is a homonymous hemanopia, check whether there is macular sparing by bringing in the pen horizontally. So the direction is important, horizontally from the side. From the side means from the defective side, the side where there is a field defect, towards the point of fixation. If the pen is seen before the midpoint here means the vertical meridian, the macula is spared. Okay? Again, there is no time for this in the exam, but if you find homonymous hemanopia and you told the examiner that I need to check macular sparing and macular splitting and obeying the vertical meridian, you are going to impress the examiner by saying this. But again, you have to know why? What's the difference between macular splitting and macular splitting? What's the significance? And we are going to talk about the significance in the next classes. So let's go back to the video. So I'm holding, note how I hold the red pen horizontally. Suppose the temporal half is affected, okay? So, so here, for example, not seen. But if I move closer, yeah, it's very hard to explain on the video, but I think the animation is better. Last time about macular splitting, the red target is seen after crossing the vertical meridian. Macular sparing, the red pen is seen before crossing the vertical meridian. How about obeying the vertical meridian? I will explain on the slide first. By the way, this is a schematic representation of the visual field defect. And as you can see here, the red pen is not seen on the right temporal here and the right nasal field here. This is right homonymous hymenopia, right homonymous hymenopia, for those who are confused. So the red pen is not seen, but seen once across the vertical meridian above. So from the upper temporal to the upper nasal, and afterwards, and again from the lower temporal, once across the vertical meridian, it is seen in the lower nasal, and so on. So this means it respects the vertical meridian. In the left eye here, this is a nasal field. Again, because in right homonymous hymenopia, we have the temporal field effect of the right eye and the nasal field of the left eye. So not seen here. It's seen after crossing the vertical meridian in the temporal field and so on, and afterwards, again, in the lower nasal, and it becomes, it's seen after crossing the vertical meridian in the lower temporal. So this means that it's respecting the vertical meridian. And this is the video. I'm just acting out because this patient, this is a volunteer, how to obey the vertical meridian. So here I'm in the inferior temporal quadrant. Here I'm trying to fixate the patient's head first because it was not aligned. So here is the inferior temporal quadrant. And moving until the inferior nasal quadrant, horizontally. Okay, and here is the upper temporal quadrant. And then moving it horizontal, so I'm adjusting my hand. So and then moving it horizontally to the upper nasal quadrant. Last time, if you notice that you have a homonymous hymenopia, like this case, right, homonymous hymenopia, and you have to check for vertical, does it obey the vertical meridian or not? And it has a significance, and we'll talk about the significance later on in the next two classes. So you notice a pattern. You notice that the targets are seen once they cross the vertical meridian. From here, from the upper temporal to the upper nasal, from the lower temporal to the lower nasal, and here in the left eye, from the upper nasal to the upper temporal, from the lower nasal to the lower temporal. This means this defect respects the vertical meridian in homonymous hymenopia. And by the way, we can use it in bitemporal hymenopia. Sorry, it's too much information today, but if you notice here, there is something called desaturation. Sometimes it is like not yes or no. Here the patient sees the red pen, but it's washed out. It's desaturated, okay? This is, by the way, the temporal field, because this is a blind spot. This is a temporal field of the right eye. And again, the red pen are washed out, okay, in the temporal field, the blind spot of the left eye. So we have here bitemporal hymenopia, okay? So bitemporal hymenopia, due to pituitary or chiasmal lesion or something, okay? You can also check does it obey or respect the vertical meridian or not. So the patient will say, for example, it is washed out here, but once it crossed the vertical meridian and it becomes in the nasal field, it became like red, like dark red. So you notice a pattern. It's not seen, but it's washed out. Still, this is a defect. Remember, the concept of visual field is a 3D. It's not about seen or not seen. Sometimes there is lower sensitivity. Sometimes there's some affection of the sensitivity. So still, the patient can see it as red, but not as red as normal. It's washed out. So this is an example of bitemporal homonopia respecting the vertical meridian with the concept of desaturation. The patient still see the target, but not dark red. It's washed out. I made an animation for the altitudinal defect. If you have a case with altitudinal defect, the next step should be to see if it is respecting the horizontal meridian or not. I'm using animation here. You are moving the pen so in the lower, it is not seen. Once you cross to the horizontal, so here the horizontal meridian, it's seen. And you do it on the other quadrant. It wasn't seen, but once you cross the horizontal meridian, it's seen. So this is an altitudinal defect respecting the horizontal meridian, and it has a significance. It has a correlation with a specific disorders. All right. So as you can see, there is some additional steps depending on the results of the previous steps. Again, don't forget the other eye. It's really important. One of the fatal mistakes that you miss the other eye, because you will never diagnose homonymous homonopia or bitemporal homonopia without checking the other eye. So you need the other eye. It will help you in differential diagnosis, because some disorder cause monocular visual field defect, other disorder cause binocular visual field defects. So you have to repeat all the steps, check the vision. Can the patient count can they count fingers? Step 1, counting fingers. And then does he see the white pen and do the mapping of the outer limit of the peripheral field by the white pen? Here's upper temporal, the lower temporal. Don't forget to shift hands. By the way, before you shift your hand, just encourage the patient to keep their eyes closed, because some patients have the tendency to imitate you. So once you shift your hands, they might shift their hands as well. And here, using the red pen to check for any scotomas for the central field. Here's the upper temporal central field. So notice the language I'm using. The upper temporal central field. Move it, move it, move it, move it until the fixation point. And here is the lower temporal central field. Move it, move it, move it until the fixation point. Shift hands. And here is the upper nasal of the left eye of the central field until the fixation point. Lower nasal field of the left eye, the central field. Move it until the fixation point. And again, here mapping the blind spot, you should map it in the temporal field of the left eye, but it's not, you can't appreciate it from this angle of photographing. So here is, at least you can notice how I was moving my hand up and down to limit the extent of the blind spot. And don't forget to thank the patient and everyone at the exam venue at the end. And as you can see here, I wrote everything in on a paper in order not to forget anything during recording. All right. So this is a 1 million question. Do I need to do all the steps on one eye, like counting fingers, white pen? Let's talk about 3 steps, because mapping on blind spot, I think it's there is no place for it in the exam because it takes time. So if we are talking about just the basic 3 steps, counting fingers, white pen, red pen, do I need to do all the steps in one eye, the right eye, then shift to the other eye? Or shall I use counting fingers on right and left eye? Yeah, like right eye first and then left eye, and then do the next step on right eye and the left eye, like one step at a time. Both are correct, okay? To make it short and to make it like political answer, both are correct. Personally, I prefer to do one step at a time. So you do counting fingers on one eye, then counting fingers to the other eye. Then using the white pen on right eye, then the white pen on the left eye. Lastly, the red pen on the right eye, then the red pen on the other eye, okay? But if you are familiar or happy or confident with some references that say all the steps in one eye, then the other, go ahead, it's not hard. But remember the abnormality, okay? You have to be focused and while you are doing the technique. The last step in the checklist called light projection. Light projection. And if you remember that slide, in the previous class, I said here, one of the tools, pen torch. Okay? We haven't talked about pen torch so far, but this is the time to talk about right now. What if the patient has poor vision? He or she cannot see, or cannot be able to see the red pen, white pen, and counting fingers. Like they have like hand motion. Their vision is hand motion, or their vision is PL. Okay? There is a test called light projection. Now I'm going to show you how we do a light projection test. First, as you can see from the dim appearance of this video, that you have to, this is an additional point, like adding another instruction that you have to turn off the lights, okay? So turn the room's lights off. Again, the same instruction, monocular testing. Patient should fixate as much as they can, okay? Although sometimes it's not possible. And then you try to direct the light or shine the light from each direction. Like, for example, let's start from the beginning here. Like here, lower temporal, and you ask the patient, inquire about what direction does the light come. So as you can see here, the volunteer is pointing to the direction actually. So sometimes pointing is easier to say than saying it verbally. And I'm also, by the way, there is no need to, so in the video, I was actually closing my right eye, but actually there is no need to do this, okay? So the examiner, yeah, the examiner may be like using both hands, but I don't know why I was covering my right eye. So simply you are shining the light from each direction. Once more, this is called light projection test. It's a kind of testing the vision, the periphery of the retina by using the light in patient with poor vision, like hand motion or perception of light. So this is a paragraph. This is useful in those with very poor vision. A bright light is shown into the eye in each quadrant and switched on and off. Be careful about the click. So the patient may notice the click, the sound of switching on. The patient has to say when the light is seen, or the direction from the direction from which the light is coming. And each quadrant of the eye is tested in turn. And it's important to ensure that the fellow eye is completely occluded. And again, I missed to incorporate here, you have to turn the room lights off. And here the comparison between two confusing tests. So we have something called light perception test. This is one of the assessment of vision. In light perception test, you are directing the pen torch exactly opposite to the eye. But in light projection test, which is a visual field testing, you are like you showing the line in each quadrant from diagonally also. And the patient is asked to point from where the light is coming. Okay? So light perception, light projection. Actually, we can't abbreviate this test because it's like LP or PL. It's the same. Okay? So when we do light perception test, if we want to check the vision and the patient can't see the charts, can't see the counting finger, can't see, and then can't see the hand motion, the next step to check whether they see light or not, like PL or no PL, like perception of light or no perception of light. In both tests, the room lights should be turned off. Don't forget this additional instruction. Hey, we finished the checklist finally, all the steps. And I'm going to show you the full video in the recorded version of this lecture, of this class. Okay, and be careful about the language you are using when you are giving the patient the instruction, okay? Because you might be familiar with the technique, but using your mother tongue. So in my area, for example, I say these instructions, I'm talking. So in this video, I was talking to him in Arabic. So, but you have to familiarize yourself with how to say it in English, okay? So you have to practice the language because patient understanding and cooperation is crucial. Many instructions are given throughout the test. For example, you have to practice, please, and to have to use specific language and give clear instruction. Like, for example, cover your left eye. You have to say left eye. And you may need to point at it by your left hand and look at my left eye. Like, can you see this? Can you see this red pen? Please tell me when you see it. Please tell me when you see it as red as this and not as another color. So practice this. Yeah, as I said before, you can use also, while giving instruction, verbal and non-verbal cues, like gestures. You can point. So in this photo, I'm pointing at his left hand to use it to cover his left eye, for example. Okay? And the patient actually may use the same. He, instead of saying, I see the light from the outer quadrants, they may point at the direction of light, for example, or the direction of whatever, okay? And here, don't call me crazy, so you may need to practice doing the test alone. So just to train your joints, your arms, how to place your hands, okay? And you know how to hold up your fingers, how you hold the neurological pin in proper way, okay? And see if you miss any steps. Like, for example, here, I didn't miss to take off my glasses, but you may miss, who knows? So practice using it in order to be familiarized with technique and to become like an automatic, like a second nature, okay? Yeah, how to cover your eyes, either by your palm or voluntarily, and so on. And see your recorded video, and sometimes you don't have anyone to give you feedback, so you might need to give yourself like some feedback or self-appraisal. Okay, so just to train your arms how to hold up your fingers and place your hands. And yeah, no, so note the recorded, note for anything you missed. So here are some of the points, like you have to have a control over the fixation. Patient should fixate on your eyes. The patient's head should be stationary. Your hand placement should be at the correct exact location. Don't forget the other eye, unless the examiner asks you to do on one eye, for example, or we have a prosthetic eye on the other eye. Switch hands, for example, when testing the nasal fields. Be careful, don't confuse by using the pen torch and the fingers, because in vision testing versus visual field testing. So, you know, we use pen torch to test the vision, but the pen torch should be held exactly in front of the eye. We use counting fingers to test the vision, but the finger should be held just in front of the eye. And by the way, when we are using counting finger to test the vision, don't present one finger, because you depend on discrimination between two targets or two things. So when you are using counting fingers for testing vision, you should use 2 or 3, or don't use one finger. However, in visual field testing, you can present one finger in each quadrant. And try to write down, if you are not familiar with the test, sometimes writing help you memorize things. All right, so in 2023, actually, I used to give candidates like some assignments. So you can actually do this assignment, for example. So like kindly make a video showing us how do you perform a confrontation visual test. Then in the last part of the video, instruct the volunteer to pretend. We'll see in the next class how we can induce a heterogenic visual field effect and do it on any family member. Okay, so candidate usually will send me a video. Okay, but this is from the past. It is something no longer available right now. And the next step that I would give them like feedback. And what's the next step? You should reflect, okay, and try to improve and like their technique and like try to fix up any mistakes they are doing. So actually, feedback is an important point or process stage in the learning cycle. Once you get a feedback from your senior, from your colleague, okay, you have to reflect on your mistakes, and you have to keep practicing, improve your action in order to have a decent, excellent way of performing any test, okay? Another inquiry about visual field. A quick question, kindly give a reply at the earliest, please. So in clinical section, visual field examination. So here's someone asked about in peripheral field examination with white pen, should we brought it until the center, until the point of fixation? As I said before, there is a variation in the techniques. Some use the white pen until the fixation point. It's okay, you can do it. But you have to keep in mind that in order to like check the central field, like increase the sensitivity, you have to use the red pen, okay? So this is my reply to her. Examiners are well aware of the very much variability of techniques. Okay, so just relax. The red pen is more sensitive and specific for testing the central field, mapping scotoma, including blind spot, checking whether the defect obeys the vertical meridian, and macular sparing in case of hemanopias. The most important is to avoid major mistakes. For example, not asking the patient to cover one eye, not giving instruction on fixation, or problems in interpretation of the results. So, for example, what just happened today is that instead of saying right homonymous, you told the examiner this is left. The most important to focus on is to avoid major mistakes, silly mistakes. And actually, Dr. Logan, the staff members in charge of neuro classes, supported my reply, and he added on that additionally, you should be able to explain what you want to find with each pins. So this is why I said earlier, you have to involve the examiner while doing the test. Also remember that you are sitting opposite the patient, and any description must be based on how patients see the fields. So we're going to talk about how we document and report the findings in the next class. Don't worry. One last inquiry about, can the confrontation test be normal in the exam? Yes, it might be, okay? And here is my sarcastic reply. So I replied by saying they brought in a case with black comediones. Remember one experience in one venue, they brought a case of black comediones in the oculoplastic station. So normal confrontation visual field wouldn't be a surprise. So you have to familiarize with both normal findings, which is essential step, and then abnormal findings. So we are done with the second class, and be prepared because the next class will be more overwhelming, a bit longer. Okay, we're going about cases, and I will show you how we can induce a heterogenic field defect. Okay, and I hope instead of being confused, you become less confused today. Thank you, everyone. Have a nice evening. Bye-bye.